Hello friends, today we're going to talk about pediatric COVID-19 and we will be talking about what we have learned so far from the global experiences. We will be talking about some of the clinical practice points in pediatric COVID-19 and also some of the public health aspects as well. So the objectives of today's talk is to summarize what we know so far in context of the basic clinical sciences regarding this infection and what we have learned so far from the global experiences. We would also be touching on some of the current controversies in pediatric COVID-19 practice, and we would be looking at some way forward out of this pandemic as well. So, starting with the basic epidemiology of pediatric COVID-19 infections. Now, despite predisposition of children to viral infections, kids usually they get repeated viral infections. Still, despite that fact, children represent a very small percentage of COVID-19 infections. And the global data tells us that in United States, only 5% of those affected have been the pediatric cases. In China, only 2% of the population affected was in the pediatric age group. And in Italy, it was just 1.2% of the population that was affected. The thing is that if we look into the mortality statistics, mortality is also very low. In USA till date, they have just reported 3 deaths. In UK also, we have seen so far only 3 deaths in the pediatric age group. In Italy, they haven't reported any pediatric deaths. So that simply means that mortality as well as morbidity is quite low in the pediatric age group. Now, among the pediatric age group, that is anywhere from 0 till 18 years of age, the median age, that means 50% of those cases which were in this age bracket, they were around 6 to 7 years of age. The incubation period we know is around 2 to 14 days, but the median is around 5 to 7 days. We also know so far that the viral shedding can be found in the feces of children up to 22 days of the infection, and in some cases it has been reported that it may go up to 30 days. But the thing is that despite having viral shedding, so far they haven't reported any active virus being isolated in the fecal matter of the affected children. So the thing is that they have found viral shedding in forms of viral components, but the viral cultures have come out to be negative. Now, those kids who have been affected, the data shows that there has been some human-to-human transmission in selected households where they had some adult contacts as well. Now, as far as the pediatric age group is concerned, infants and neonates, most of the time they have been seen that they were largely asymptomatic, though despite the fact that many had positive or symptomatic adult contacts. Now, the largest review of children with COVID-19, that was a study which was done in China. It included 2,143 children, and they found out that only 5 to 6% of those children, around 112, had severe disease, which was they defined as a hypoxia, and only 0.6% children, they developed respiratory or multi-organ failure or acute respiratory distress syndrome, or they required some form of intensive care therapy. So the thing is that the fraction of or the percentage of children who went into severe disease was quite low, just 0.6% of the total cases. Now, the case reports of fatalities have been published, and we know so far that most of them who died in the pediatric age bracket, they had underlying medical conditions. And we have also seen, just like in the adult population, males are affected more as compared to the females. Now, let's talk a little bit about the coronavirus family. Now, coronaviruses are known to be causing infection in animals, basically. And the coronaviruses have been divided into different subtypes: alpha, beta, gamma. The alpha coronavirus 229E and NL63, while the beta coronavirus OC43 and HKU1, they are known to cause common cold in humans, more so in kids. Some of the beta coronaviruses like the Middle Eastern Respiratory Syndrome coronavirus, the SARS-CoV-1 and SARS-CoV-2 have been known to cause severe illness in children as well as in adults, mostly adults. Now, coming down to the basic pathophysiology in children, this is an RNA virus. It's a 30 kilobytes genome which is covered by surface proteins. These proteins have got spikes, that's why it is known as coronavirus, and they have got affinity for ACE2 receptor, which is the angiotensin converting enzyme 2 receptors. Now, we know for sure that there is abundance of these ACE2 receptors in the type 2 pneumocytes in alveoli, which are known for producing surfactant. The recent research has also shown that ACE2 receptors are not only found in the alveoli, but they are found in many other organs, and especially the upper respiratory tract, including the oropharynx, including mouth and tongue. It has got a lot of ACE2 receptors. Rather, they say that children have got relatively less ACE2 receptors in their lung as compared to the mouth. So mouth and oropharynx has got more ACE2 receptors as compared to alveoli. And that is perhaps one of the reasons that kids mostly present with mild disease, which is mostly involving the upper respiratory tract rather than the lower respiratory tract. And at the same time, in kids, repeated exposure to other variants of coronavirus, like I said, alpha coronavirus 229E, NL63, and beta OCE43 and HKU1, because kids get these common colds around the year, there is some form of immunity which develops in them, and this cross immunity is thought that it might give some form of protection against SARS-CoV-2 as well. We also know that most of the kids have got asymptomatic or very mild illness, but we do know for sure as well that there is some stealth infection which occurs in kids, and as I said earlier, that viral shedding has been reported to go on in some cases up to 30 days. Now, as far as the case definitions are concerned, in China, this is like a confirmed case is a child who tests positive for COVID-19, but mostly the problems are with the COVID-19 suspects, and they defined COVID-19 suspect as someone who was in a high risk, like someone who was had some form of community exposure with any two of the following points, and those following points were fever with respiratory symptoms and or diarrhea, vomiting, a normal or low white blood cell count with some raised C-reactive protein, and an abnormal chest X-ray. So if they had got fever, respiratory symptoms, or they had low or normal white blood cell count plus minus raised CRP, or they had just abnormal chest X-ray. So any two of these 3 points, plus a history of exposure or coming from a high risk area, like where there have been active cases or where there was a case in the household, that was defined as a COVID-19 suspect. And on that criteria, in China, of 2,143 pediatric patients, who were actually tested, only 34% of these suspects, they came out to be positive. So the positive predictive value of this case definition is only 34%. It simply means that out of, let's say, if you've got 100 people who are fulfilling this definition, only 34% of them would be having actual COVID-19, which is quite low. And this was already, they actually found this out in a research on a large cohort of kids, 2,143 in China. Now, coming to the types of COVID-19 illnesses in pediatrics. So there are actually 5 groups of the illness, which are asymptomatic, mild disease, moderate disease, severe disease, and critical disease. And among this data, which they actually collected in China, they found out that only 4.4% of the kids were asymptomatic, 50.9 and 38.8% respectively had mild to moderate form of the illness. So they had either primarily very mild upper respiratory symptoms, or they had just like off and on fever with some cough, wheezing, but they were not hypoxemic. And the thing is that they had very mild symptoms. So this, if you look at asymptomatic with mild and moderate, so that constituted around 94% of the cases. Only around 6% of the cases they fell in the severe and critical category. And again, if you look at the critical category, which developed acute respiratory distress syndrome or had developed shock or developed organ failure, they were just 0.6% of the total pediatric cases. So we see here that it's mostly the asymptomatic form or very mild to moderate form, which can mostly be treated at home just with isolation. At the same time, in the United States, they actually compared the data of children and compared it with the adults, and this was published in the Morbidity and Mortality Weekly Review, dated April the 2nd, 2020. And in this, they actually tried to find out the similarities between the children as well as the adults, and they found out that it was mostly fever, cough, or shortness of breath, which was present in 73% of pediatric cases, while it was present in 93% of the adult cases. So adult, they present more with fever, cough, or shortness of breath, while in children only three-fourths of the cases they actually presented with this fever, cough, shortness of breath. Rest of the symptoms are also present in minority of cases. Mostly it was headache that was present in around 28% of the kids, while it was present in 58% of the adult cases. So moving back, the London School of Tropical Medicine and Hygiene, they did a mathematical modeling which was published in one of the papers, and I would show you this paper. And they actually looked at three hypotheses. So the first hypothesis was that they thought that there would be a sort of mixing patterns and reactive school closures, which actually decreases mixing between children. The other hypothesis was if the children exhibit low susceptibility to infection, or number three, if children have got a low propensity to show clinical symptoms. So they took these three hypotheses and they tried to model it out in the current pandemic, and to see how what would be implication of these three different hypotheses. And they found out that there was a strong age dependence in probability of developing clinical symptoms, rising from around 20% in under 10s to over 70% in older infants. And they concluded that interventions aimed at halting transmission in children may have minimal effects on preventing cases depending on the relative transmissibility of subclinical infections. So this modeling actually shows that that the children have got very low role in transmitting this infection, and this is quite sort of what you call the strange thing, that we normally, it was thought that it actually spreads with close contacts, but somehow this modeling showed that in case of children, they are not primarily responsible for spreading it in the community. Now there have been guidelines published for maternal COVID-19 as well, and it says that such cases should be dealt separately from the, especially if they are being delivered, they should be delivered in a special room which must have got negative pressure to minimize the chances of aerosol generation. The mother should be wearing a mask, and the partner should not be loud, rather there should be visual interaction with the partner, and the attending staff should be wearing full full protective gowns and goggles and N95 or FFP3 masks, and there should be no skin to skin contact once the baby is being born. There should be delayed cord clamping, and the baby should be transported in a sort of a separate baby So baby should be transported in a separate trolley, and then his COVID-19 testing should be done at 12 hours and 24 hours. Okay, now moving on to an interesting case, and this case was described as a case report. This was a case 0 which happened in the United States of America, and they have already published it in one of the journals. And this case was in Atlanta, Georgia. She was a 12 years old girl of South African origin, and she came to day 2 of illness to the emergency department in one of the hospitals with a history of fever and vomiting. So she was given some medication and she was sent back. On day 3 of the illness, she returned back, re-attended the ED with a history of persistent fever. Now she had developed a new cough, and she also complained of some blood coming in her urine. So again, was treated symptomatically, was sent back home. But again, on day 5 of the illness, she again returned to the emergency department with a high-grade fever. She had now developed some shortness of breath on the top of the cough. The temperature was 39.6 degrees Celsius. Heart rate was 129. Respiratory rate was fluctuating between 26 to 36, and O2 sats were 89% on room air. So you can see that she was febrile, she was tachypneic, tachycardic with low O2 sats. So she was started on high flow nasal cannula, but she couldn't tolerate that. That increased her distress. So she was transferred to a pediatric intensive care unit, and she was started on non-invasive ventilation, BiPAP. Now, the background history was that she was a student of the 6th grade. She hadn't had any sick contacts at home, or she hadn't had any contact with any COVID-19 positive patient. There was no history of travel outside of Georgia, United States, in her recent past. The laboratory profile showed, actually, if you see, there was low sodium 132. This is actually the skeleton diagram of the chemistry 7. So a little bit of low sodium, potassium was 3.5, chloride and bicarbonate, and similarly creatinine and blood urea nitrogen were normal. You can see that her AST was mildly raised at 37. Then she had elevated acute phase reactants like procalcitonin, ferritin. Similarly, her interleukin-6 gamma interferon levels were raised. Her platelet count was quite low. It was less than 10 into 10 to the power 9, and she had the absolute lymphocyte count was quite low. So she had a bit of lymphopenia. So on the first day of hospitalization, that was the day 5th of the illness, a chest X-ray was done, and I will show you this chest X-ray in full resolution. So you can see that the chest X-ray on day 1 was showing bilateral opacities more on the right side with some pleural effusion as well. And then on the 3rd day of hospitalization, you can see now that the right lung is full of ground glass opacities. They've been on the left side as well. So she had developed acute respiratory distress syndrome by the 3rd day. So the treatment that was started on the 2nd day of hospitalization, which was the 7th day of her illness, because of the increasing distress, she had to be intubated, and she was started on inhaled nitric oxide. Because of the low platelet count, she was also given intravenous immunoglobulin and was started on solumedrol, which is methylprednisolone, in order to tackle the low platelets count. And she was also given noradrenaline, which they call as norepinephrine in the United States. That was given for hypertension because they thought she was probably developing septic shock. She was also started on broad spectrum antibiotics, vancomycin, ceftriaxone, azithromycin. So that was vancomycin was covering the gram positive, especially the MRSA, ceftriaxone for the gram negative, and azithromycin for atypical bacteria. So she had a very good broad spectrum coverage, but she didn't respond to that. So on the 5th day of hospitalization, her COVID-19 test, which was done, that came out to be positive. So the doctors there, they stopped azithromycin and they started her on hydroxychloroquine. By this time, because of the IVIG, solumedrol, and some platelets transfusion which was given, her platelet count has raised above 100, and she hadn't had any other cytopenias. Because of the low blood pressure. They thought that she was probably developing adrenal insufficiency, and that's why corticosteroid was also given. And by this time, her maximum temperature was now 38.3 degrees Celsius. Now, on the 8th day of hospitalization, again, if you look at these X-rays, you can see that there has been now some resolution. Like the on the right side, you can still see ground glass opacities, but the upper part of the lungs probably you can see that they are now starting to clear up. And on this day, they started giving her remdesivir, which is an antiviral drug, and at the same time she was also started on a drug, on a monoclonal antibody against interleukin 6, which is known as tocilizumab. And within a day, you can see on the 9th day, the lungs have become quite clear. So there's a striking difference between the two chest X-rays, which were just done 24 hours apart, and you can see how much the lungs have improved, how much the infection has cleared. And by this time, the temperature was now only 38.1 degree Celsius. So to some extent, remdesivir and this interleukin 6 monoclonal antibody probably had done the magic, and the girl's lung were now showing a lot of improvement. The further course was that she was weaned off of inhaled nitric oxide. 36 hours after these drugs were administered, she was ultimately extubated on day 15 of the hospitalization, and then went inpatient rehabilitation, and she fully recovered. And you can also see that the LFTs, they increased. So that's why only 5 days of remdesivir was given, because remdesivir is known to increase LFTs. Now, the thing is that this leads to certain challenges in pediatrics, because number one, we know that there's just been limited cases in terms, in context of pediatrics all over the world, and there have been limited trials which have specifically looked at the pediatric cases. So dose considerations are always a tricky thing. They are quite controversial. What doses have to be given, like remdesivir, if the general consensus at the moment is that, like, if they are more than 40 kilograms, then 200 milligram of remdesivir has to be given. Below that, it has to be given another per kilogram body weight. Similarly, we don't know whether the children are recovering because of these different types of drugs being given to them, or they are simply recovering on their own. So in this particular case, from day 12 of the illness, she started showing a lot of improvement. And then, within 24 hours, the chest X-rays were so much clear that after that she had to be extubated, and she did very well after that. So the basic dictum here is that different trials of different drugs can be given. But the fact is that if there are no guidelines, if there's nothing, it's best to do no harm. So not to give anything and just watch and just give supportive treatment in such cases. Now, the public health aspects of COVID-19. We know that there are phases when there's a pandemic. There's a containment phase and there's a mitigation phase. Containment phase is when you try to track down every infected case, and then you try to track down their contacts with extensive testing, and once you find them out, you isolate them or quarantine them, and this way you try to reduce the spread of the disease. But usually it works in those types of diseases in which the symptomatology is quite clear. There are pathognomonic signs, and it's easy to detect the cases. In case of COVID-19, especially in pediatrics, we know that most of them, they've got asymptomatic, or they've got like very mild illnesses, which are most of the time indistinguishable from other forms of illnesses like common cold, upper respiratory tract infections. So it's very difficult to know whether this is being caused by COVID-19 or whether this is being caused by any other different type of viruses. And we know that testing is quite expensive, so we cannot go on and test each and everyone who's got some upper respiratory symptoms. So that's why containment usually doesn't work in this type of pandemic, where mostly the disease is quite mild or is asymptomatic. Mitigation is the second phase. If you can't do containment, then mitigation simply means that going for those sort of measures which try to spread the spread of the disease. And these are quite crude measures, like lockdowns, uh, putting people in compulsory sort of confinement in their homes, and different types of these things have been practiced all over the world with mixed results. And to some extent they have produced some results, as well as we can see that in various countries the curve is now flattening. But again, this has to be taken with a pinch of salt, because this doesn't mean that the total number of cases would reduce or the infection won't spread. It simply is reducing what we call the number of given cases at any given point in time. The thing is that the total number of cases would still be the same. The only thing is they would be more spread over a period of time, so that the health services can cope with the burden of the patients. Then they'll be talking about herd immunity as well. And Sweden is one of those countries in the European Union which has been experimenting. So they have actually practiced partial lockdown. So they have allowed people to gather in groups of up to 50. And the chief epidemiologist of Sweden was on the TV the other day, and he said, like, we want the mass to develop herd immunity, but at the same time we want to protect the vulnerable, the aged population as well. So they are experimenting with a mix. And the thing is that the number of population, or the percentage of population that has been affected, again, if you compare the Swedish population that has been affected with other countries which have practiced strict lockdowns, you see that there's very little difference. Like 0.3% of the population has tested positive, or or is being affected by this illness in Sweden, and 0.28 in Finland and other countries which are which are actually practicing compulsory lockdowns. So very little difference. But obviously the case fatality has been a bit high in Sweden, again because most of those in the nursing homes and care homes, they have been affected. So mixed results from different types of experimentations. But again, the underlying dictum is that if somewhere around 50 to 60%, 67% of the population either gets infected or develops immunity because of one reason or the other, then the spread of this disease would eventually die down in the communities. Then there is some talk about the vaccination as well. Different trials of different types of vaccine against COVID-19 have started. Some trials have started in UK, and I think probably within a week some trial would also start here in UK as well. But still a long way to go. We still have to see how much effective these vaccines are in reducing the number of infections. And then there is another way which very few people are talking about, and that is prophylaxis. And well, we know that certainly there is no drug prophylaxis for COVID-19 because it's a viral illness, and the antivirals, again, which have been used, they have shown mixed results. And obviously we do not have any randomized controlled trials to see whether these things, they really work or not. But I think in such cases, we can, in such types of situations, we can go for some innocent things as a prophylaxis, and that is prophylaxis to boost up your immunity. So using nutrients or minerals which are known to increase or boost your immunity, like vitamin C, zinc, vitamin D, etc., they can be tried, because the thing is that they are usually nutrient products. So unlike antiviral drugs, they don't have much toxicity, and they can be given on a trial basis to see, because they are known to boost up the immunity, and that might add up in preventing some segments of the society from getting this infection. So prophylaxis is worth trying, and we can see whether it leads to any decline in number of new cases or not. So in short, to summarize this whole pediatric COVID-19, the facts are that pediatric COVID-19 is less prevalent as compared to the adult COVID-19. And we also know from research that most of the cases are asymptomatic, or if they are symptomatic, they've got very mild illness. The general principles of the care are the same. It's mostly symptomatic treatment, and in some cases different types of medications have been tried, mostly with mixed results. And of course, if because we don't have any concrete medicine at the moment, a trial of experimental drugs can be given till definitive protocols are available, and only time would tell whether these drugs they really make any difference or not. So thank you very much for listening to me. Stay safe, stay healthy. If there are any questions or comments, please do ask me, or just you can put your comments in the segment given below. Thank you very much.